So, my name is Dr. Samaresh and I am a cataract refractive specialist working in Jaipur at Raghudeep Eye Hospital. And I wanted to discuss something interesting that we saw and we discovered in our hospital a few years ago as to what happens when we actually do a cataract surgery. Because we as surgeons are so involved in the nitty-gritty of putting an IOL and getting a visual outcome, good visual outcome. But there are certain things that are hidden behind and we don't know where we're placing the IOL in normal eyes or in eyes where, things are not right. So generally the tendency is to put an IOL in the capsular bag, and that's what all of us want to do. And that's generally a good idea. But sometimes you have patients where the bag is compromised or not there, or patients with aphakia, or if you cause an iatrogenic complication. And sometimes when we place these lenses, we really don't know what's happening behind the iris, and we don't know what tissues we are manipulating. So we decided to create our own version of a Miyake Apple View in our clinic. We found a very nice old microscope, operating microscope, and we decided to break it apart and mount it upside down on a table. So as you can see, there's a Zeiss microscope that's mounted upside down, which has a camera, including both a regular and a high-speed camera. So the idea is to use a cadaveric eye, sectioned cadaveric eye, stick it half onto a slide, operate from the top as you would do a cataract surgery or any other ocular IOL fixation, and to record the surgery from the bottom as to see what's happening inside the eye when it's being done and what is the outcome like. So one classical example we'll start with is a patient with subluxation or a zonular dialysis, where we would try to do a capsular bag fixation rather than eating it all out. So most often we are challenged with cases like these, where we have to understand that whether it is important to preserve the capsular bag or one should remove the capsular bag and go ahead and put a newer technique of fixation like a glued IOL or a Yamane fixation. What we need to understand is when we put an IOL inside the eye, the foreign material, hydrophilic, hydrophobic, PMMA, whatever, is shielded from the rest of the ocular tissues by the natural capsular bag, which is an alive tissue. And as you can see over here, this is a patient who's had a CONE fixation. You can see the element over here. But you can see that a hydrophobic lens is well placed. You can see the CTR there. And it's completely shielded from the rest of the ocular tissues, the anterior vitreous face, and the iris uveal tissue with the capsular bag, which is as close to normal human physiological anatomy as we can be. But sometimes the lenses are so dislocated that there is no other option but to go ahead and do a complete vitrectomy for these patients with the lensectomy. So like I said, this is a well fixated capsular bag using a CONE, and as you can see, the haptics are there, and the capsular bag, and even the CTR ring is being shielded very comfortably. And there's only one point of fixation. We need to understand that the anterior vitreous face and the posterior capsule is not only there as an anatomical barrier, but it also provides functional stability to the eye and prevents the movement of free radicals, the diabetic changes from the anterior to posterior compartment and vice versa. But we are not able to retain it at all time points. Like here, it's a spherophakia with dislocate, so we need to take out the entire capsular bag lens complex. And we are left with an eye that has no structure in it, and now the compartmentalization is gone. So the anterior and posterior chamber is one, as you can see over here. In this case, age-old technique is to use a scleral fixated IOL. And so in this patient, when we go ahead and fixate a scleral fixation, this is a 2-point fixation using a Gore-Tex suture. Gore-Tex again is an off-label use for ophthalmology, but it's being used very commonly now. Our standard dictum is to go 1.5 millimeters from the limbus and do a fixation of an IOL there. And this is a PMMA IOL typically. Now this is how the IOL would look if you were to see it from inside the eye. That's the fixation points, but notice how the haptics go beyond the fixation and rub through the ciliary processes all the way. This is a larger IOL, and it's very anteriorly placed. As you can see, it's almost touching the iris tissue. Now if you were to leave a lens like this inside the eye, there'll be constant rubbing between the iris tissue, ciliary processes, and these PMMA lenses that could potentially lead to what is known as a long-standing uveitis, glaucoma, hyphema sort of a picture. Another more popular technique now, because it's easier to do and it's also the learning curve is lesser, is intrascleral fixation by one of many ways. So this is just to show you a classical intrascleral fixation using a glued IOL technique. Now we are using posterior chamber lenses to do glued IOL. So we have to understand that these lenses are meant for bag fixation or sulcus fixation, but not meant for intrascleral fixation. The haptics and the design of which are not conducive for that fixation. So when we are manipulating, when we are trying to externalize these haptics, sometimes we break or we kink these haptics, as you can see over here. Something that we would not really see because we are so focused on fitting the IOL inside the eye that we sometimes tend to overlook and miss out these subtle findings. Notice how the haptics again, which are over here, again as you can see, are going through the ciliary processes and out, and this will definitely lead to some sort of a uveitic picture in the eye if the eye is prone to it. So we decided to see what, where we are fixating. So this is us at 1.5 millimeters from the limbus, and you notice you're going straight through the ciliary processes. The standard dictum of where you should place the lenses goes straight through the ciliary processes, and it's the pro-inflammatory area of the eye. What if we could try going a little posterior? Maybe a 2 mm posterior fixation. As you can see over here in the cadaveric eyes, this is 1.5 from the limbus, 1.5 mm from the limbus, and you're straight through the uveal tissue. And at 2 millimeters, generally you tend to avoid the uveal tissue and you get into the lesser inflammatory part of the eye, where the eye is supposed to be more quiet. But that also means the IOL is going to fix so much more posterior from the iris. And again, very difficult with these bag fixation scleral lenses, 3-piece lenses, because they're meant for anterior fixation, so the haptics are not that long. Just to show you a Gore-Tex suture going straight through the ciliary processes, while a posterior fixation of a scleral fixation using Gore-Tex going out of the ciliary processes. Now these PMMA lenses can actually be fixated a little posterior because the haptics are big and the IOL itself is a little bigger, so it can go back. So this is the sweet spot for fixation of an IOL, at the junction of the pars plana and the pars plicata. But it's anyone's guess as to where it is, because all eyes have different anatomies. Myopic eyes will behave different from hyperopic eyes. So we decided to understand if there's any way we can find out where there is a way to technique to find out which is the area of the pars plana, pars plicata junction, and that point would be a good point to fix the IOL. So here we can see that we are using an infrared light, infrared LED, much like an LED that you would get in a remote controller of your televisions, and do a transpalpebral trans-illumination. So you're putting the infrared light underneath the lower lid and lighting up the eye. And on the other hand, here I'm using a security camera, CCTV camera with a +10 lens. And I've removed the infrared filter, so the lens can pick up infrared light. And the moment you do that, you see this area of the junction of pars plana, pars plicata, which is where you want to fix the lens. So you can move from a blind procedure to an image-guided procedure, where you can now put this LED and the torch and then mark points where you want to fixate the IOL, or even not IOL, maybe give an intravitreal injection. You don't have to do a blind procedure, and you can do a targeted procedure through the safe zone of the eye. It's not new. Infrared transpalpebral trans-illumination has been used on and off and has been published for seeing intraocular tumors, and sometimes for some glaucoma procedures, but it's never really been used for any fixation techniques or any image-guided surgery. So with this in mind, with this technique in mind, we must understand that if we can somehow work this through in our clinics and try to fix the lens just a little more posterior, maybe we'll have happier patients with lesser complications in long term, and maybe these surgeries can also become image-guided. Thank you.